afternoon. On behalf of the Sri Lanka College of Cardiology and on behalf of my co-chair, let me welcome the next speaker, Dr. Sai Satish. He is going to speak on about the use of mitral clips. Can you hear us?
I can hear you very
Satish?
clearly. Good afternoon, everyone.
Good afternoon.
It feels strange not being there. Actually, this is the first year I'm missing, but at least thanks to all of you, we can do this virtually. Just shows the kind of effort you're taking to make sure learning never stops.
That's true.
So I have a brief presentation on mitral clips and mitral regurgitation. Shall I share the screen and start right away?
Sure.
Yes.
Okay, so I know you're all pressed for time and you've given me 30 minutes, but I have just a 15-minute talk. So you'll be relieved to know that you'll make up 15 minutes in my talk. Okay, so good afternoon, everyone. I'm going to jump straight into my talk in interest of time. Thank you so much for the organizers for having me there with you today. Like I said, I wish it could be in person, but I think for another year, this will have to do. I'm going to give you a brief update on mitral regurgitation and mitral clip therapy. So this is a beautiful article written by John Jones and Wahab, which talks about the incidence of aortic stenosis. Now, several articles say that the commonest heart disease that an interventional cardiologist will see, valvular heart disease, is aortic stenosis. So from the data, what we see is 1 in 8 people over the age of 75 are likely to be affected by this condition. More than 1 million cases of aortic stenosis are diagnosed per year in India alone. Now, you must be wondering, why am I talking about aortic stenosis? Because there was a beautiful article in 2006, way back in 2006, published in the Lancet that said that the estimated burden of mitral valve disease is at least 3 times that of aortic valve disease. And this graph depicts it beautifully. Now, this is US data. And what it shows is that about 1 million cases of aortic stenosis are diagnosed every year. About 4 million cases of mitral regurgitation are diagnosed every year. While only 14% of aortic stenosis is treated, less than 1.5% of mitral regurgitation is treated. So that's a staggering data, even for the United States. And this is as early as November 2016. So what do we know about heart failure? The table on the right shows you the global burden of heart failure, about 26 million cases, 1 in 5 lifetime risk of getting heart failure, underdiagnosed huge chunk of cases. And this is the data, right? Increasing life expectancy, skyrocketing incidence of hypertension, obesity, diabetes, all these roads lead to heart failure. In India alone, we have 4.6 million patients with heart failure. Of these 4.6 million patients, 30% die in hospital. And over 55% of them, that is approximately 55% of them, are readmitted within a month of discharge. We've all had heart failure patients as cardiologists, and we know that they have a very poor quality of life with a mortality as high as 57% in 5 years. Now, mitral regurgitation is a significant component in heart failure patients. Now, why is it that such a small percentage of these patients are actually treated? So, data shows that only 2% of them get surgical treatment. Why? Because a good 49% are too high risk. Impaired LV function, high operative risk, multiple comorbidities, advanced age, not fit for surgery. Now, the remaining 49% who are actually surgical candidates, half of them are not even referred for surgery, even if the indication exists. So now moving on to mitral clip. I'm not going to talk during your lunch break about data because this data has been there all the way from 2003. I'm just going to briefly touch upon the pivotal studies and what we have learned. Your feasibility study was Everest, just 55 patients. Everest 2, as 339 patients, got the CE mark. Then the realism arm of the Everest 2 got the FDA approval for DMR, or degenerative mitral regurgitation. That was a very important step in treatment of mitral regurgitation, but not as important as the COAPT study. The COAPT study showed without doubt the significant role of mitral clip therapy in a very special group of patients, the functional MR group of patients. And now we have the EXPAND, which I think deserves a short mention because Saibal just presented this. We all know Dr. Saibal Kai has been pioneering mitral clip therapy world over. And I think it's worth spending a minute on this page. 57-center global EXPAND study conducted in the United States and Europe included about 1,000 patients. Look at this, at 1 year, 89.2% of patients achieved an MR grade of less than 1+, 97.3 less than 2+, which is incredible. And most of this improvement was, if not immediate, by 30 days. Now, these results were even better than Everest 2 realism registry data, which is real-world data of mitral clip in patients with mitral regurgitation. Now, while the results were seen across both the FMR and the DMR groups, I think there were approximately around 450, 470 patients per group. They noticed that 90% of the 413 patients with functional or secondary MR have grade 1 or less MR severity at 30 days, which is not only sustained, but also improved to 93% at the end of 1 year. Now, when you look at this, this is actually better than the QAPT. In terms of functional improvement, 80% of patients, 1 second, I'm going to move this video bar out. Thank you. Yeah, there we go. So in terms of functional improvement, 80% of patients were in NYHA class 1 or class 2 by 1 month post-procedure. That is incredible. Imagine class 3 to class 4 patients by 30 days are down to class 1 to class 2, and with a very significant p-value. Even the Kansas City cardiomyopathy questionnaire score rose sharply from 47 to all the way up to 67 at 30 days. So mitral regurgitation. Now that's enough about data. So mitral regurgitation. There are 2 types of mitral regurgitation that we all have to have our eyes on. One is the primary mitral regurgitation, which happens because of leaflets, the subvalvular apparatus, the chordae, and the papillary muscle. Primarily what happens is flail mitral leaflets, your infective endocarditis, your rheumatic heart disease, all this will fall under primary mitral regurgitation. And then the other chunk of secondary mitral regurgitation or functional mitral regurgitation, which happens because of cardiomyopathies, which happens because of ischemic heart disease, annular dilatation, and leading to incomplete coaptation of the mitral valve. So what is Mitral Clip? Mitral Clip facilitates the reconstruction of insufficient mitral valve through tissue approximation. So it's a recapitulation and a refinement of the Alfieri stitch. It's very simple. It's a mechanical solution to a mechanical problem. And this repair creates a tissue bridge. Here's a short video for you to see. So that's the transeptal puncture. And as you can see, the transeptal puncture has to be mid to superior, posterior, because you want to avoid the aorta. And the reason why it has to be a little high and always mid fossa is because you need the length to bend down and enter the valve exactly where the jet is. And all this is done with 3D echocardiography. It's real time, it's beautiful. Initially, I used to look at both fluoro and echo, but now most of the time the echo images are so good and you're comfortable with your echocardiographer. This procedure is all about the echo. So you can see how you can exactly see, you've already done a TE before procedure. You've assessed where the jet is, between which leaflet it is, and you can go exactly in that segment, either A to P2 or wherever it is, dissect the jet, put your grippers down, clasp it, and this is the beauty of the therapy. After this, you can actually assess reduction MR, transmitral gradient, position of the clip, stability of the clip, and once you do all that, only then you can release the clip. Otherwise, you can just open and go back and do a recapture and see which position gets you the best possible result. And once you do all that, there are certain steps. Now, I'm not going to get into the method of doing mitral clip because it's a little more complex than other structural heart interventions. There are a lot of levers and knobs, and it gives you the entire freedom to move in all 3 dimensions inside the LA. So you can go up, you can go down, you can go left, you can go right, and you can even go in between by twisting knobs. So I'm not going to get into that right now, but I'm just going to show you that this is how the clip is deployed. And then you leave the clip there and you come out, and then you can perform a full assessment, and you can even plan your case. You can say that, okay, so there's a longer area of mitral regurgitation. I don't think I'm going to be finishing with 1 clip. So then what you do is you go to either left or right, deploy your first clip, then put the second clip and get out with the entire leak reduced as much as possible. The less the leak when you leave, the table, the better the patient will do. The better the short-term outcome, the better the long-term outcome. So now I thought I'll show you two cases, one primary and one secondary MR. So this patient was an 86-year-old lady with no diabetes or hypertension. She's a known case of mitral valve prolapse all the way from 2001. She has echoes that I have seen, which is in 2001 and 2015, was very active, playing golf, doing well until 9th March 2017. When on the golf course, she developed severe sudden shortness of breath, rushed to hospital and found to have a flail mitral leaflet with severe MR. From that day onwards, her life was miserable. 6 hospitalizations for heart failure with drastic reduction in quality of life, could hardly walk 50 meters before having to sit down. And because of her age, she was, of course, a surgical turndown as well. So in these echo images, you can see what I mean. You have both your views. One view, you can make sure you're mid-fossa, and the other view, you can make sure you're superior. And you can see from the fluoro image, first is the puncture, and just look at the second image. You'll see the clip actually can be opened and closed just like a mechanical clip. So these are fluoro images just to give you an idea of what we're doing, but most of the time we're looking in 3D echo in real time. And after the first clip deployment, we felt that there was just enough place for another clip as the MR came down to about 2+ to mild to moderate, and we wanted a good result. I quite like to leave a pigtail catheter in the LA at all points of time, which gives me continuous LA pressure. I learned this from Cybele, and makes a huge difference as you do your procedure. Because with every grasp, you can see how the LA pressure is reacting. So this is the second clip, and this is a little tricky because you've already clipped the leaflets together. So you have to go in without dislodging the first clip. You have to make sure you don't get entangled in the chordae. You have to go in neat by the side. Once you're fully confident on where you are, you confirm with echo, confirm with fluoro, then you can see both the clips floating around here, right here. You can see both the clips here. And then you take everything out.
I think we have to mute the sound there.
Oh, no problem. I'm going to mute it myself. Sorry. Is that okay now?
Yes.
Yeah, okay.
Okay. So I showed you the pre-procedure, the post-procedure. In this view, just look at the huge flail chunk right there. You can see the huge flail chunk. You can see the torrential 1.47 wide jet. And then look at the post-procedure. We got off with trace MR. So the first clip had mild to moderate. The second clip completely abolished the MR. Look at the LA pressures. Look at the V wave. It just collapsed. This is instantly pre-procedure, post-procedure. Complete resolution in LA pressures. This was the patient day 1. This was the patient day 2 at discharge. Definitely, I have requisite permissions for educational purposes to show these photos of her. Exactly 14 days after the procedure, this lady went on national television to play badminton with her grandchildren and people her age, and talked about the second lease of life she's gotten because of mitral clip therapy. So the next patient I have to show you is a patient of secondary MR. So now you've seen the flail leaflet, huge flail leaflet, and you've seen how good the result was. This is an 80-year-old male, hypertension, azotemia, creatinine was 2.5, Antrewall MI, severe LV dysfunction, severe MR, post-cardiac arrest during his MIs, revived, multiple hospitalizations, surgical turndown. So you can see how morbid these patients are and why they would be clear-cut surgical turndowns. Is there a gray box appearing on the side of the screen, like covering half of the screen for all of you?
Yeah.
Okay, I'm going to minimize it. Is it better now?
Yeah, it's smaller now.
Okay, good. Okay, perfect. Let me just remove that. Okay. So you look at this 3D echo and fluoro-guided puncher and clip deployment. So the same procedure again. You go to your 3D echo, you take your puncher, your pigtail goes in the LA, you deploy the first clip. Instantaneously, The LA pressures drop. CVP drops from 28 to 14. Look at this image here. You can see a huge non-coaptation between the tips of the leaflets. Now, and the torrential jet, right? So this is the most classical case of secondary MR you'll ever see. And when I go on to the next slide, I have yet to see, in all the cases of MR I've screened, I've yet to see a hole this big. Now, the thing is, when I did this clip, we had only the NT system in India, which is the one with the smaller arms. So I was not even sure that we could actually grasp across such a wide gap. So you can see in the deep transgastric, you can see the mitral valve, huge gap here, huge jet, huge gap in 3D reconstruction. This is the post-procedure. So we managed to get it just in place. There was 1+ MR when we finished with the procedure. The huge hole is gone. The clips were perfectly well seated, stable. And like a nice ribbon, you can see the valve beautifully clipped. It was A2P2, so you can see right in the center, beautifully clipped valve. And the mean gradient across the mitral valve was only 2 millimeters. So we did not produce any mitral stenosis. And look at this. I have yet to see a V wave of 86. So huge drop in LA pressures. And this is another patient who's very dear to me, because even one day before the procedure, nobody thought that he would benefit from the mitral clip procedure. The night before, they tell me that, look, doctor, I think I skip this procedure. I don't think I want to do it. I don't think I'll benefit. And the biggest problem spend all night just sitting up. And you can see just a few days after the procedure, he sends me a message saying, good afternoon, sir. He slept all night yesterday. Thank you for this miracle. They went on how amazing he's doing really well.
So in 2016, when my...
So I have a short 2 videos to play for you, and then I'll end the presentation. I hope I'm still on time.
Yeah.
Hello? Perfect.
So in 2016, when my dad had a heart attack, he was obviously put on certain medications. And we were using those medications for a while. And after a year, his ability to walk was decreased. Sit and concentrate or do his own things was getting limited. More so in the last 8 to 10 months, when he was not able to go use the restroom on his own, is when things started really going south. He started having pulmonary edema, which would make his legs swell, and the liquid in the lungs was making him breathless. So I think Mitral Clip was really a magic for us. And this whole process and the procedure.
An extremely sick patient who came completely bedridden. So he developed a heart attack. He had severe heart failure. The heart failure had gone to such a point that he had been bedridden for a year, and he had actually forgotten how to walk. His family was not convinced that this kind of therapy would help. They flew in from New Zealand, flew in from America. He came in all the way into the hospital. Even then, he was a bedridden patient with severe heart failure who every month needed to go to the hospital to get his pleural fluid drained and to get diuretics. And at that point of time, they were wondering, why are we even doing this therapy? But when I examined him, when I did the echo, I was absolutely convinced that he would benefit.
Thank you, Dr. Sai. This is an excellent presentation and your demonstration of patients who are very sick after the clip. I'm just asking, the conditions or the indications where you don't select patients for mitral clips, you have anything sort of contraindications?
No. So very simple. Now, as you have seen from my lecture, you can do mitral clips in, so now there's a reason, again in TCT, so I'm going to divide this into acute MR, chronic MR. In chronic MR, functional MR, and primary MR. So you have seen from my presentation, I've showed you multiple cases of chronic MR, both functional and primary. Now, recently, there was a data that's shown in TCT that even Mitral Clip can be used for two new indications. One, in acute MR. Two, as a bridge between transplant and severe mitral regurgitation. It actually holds the patient together. So when you see MR, the only limitation, in my opinion, from the way data is emerging, is the anatomical factors that allow you to put the clip safely or not. And the single most, there are predefined relative contraindications and absolute contraindications. But to cut a long story short, depending on the expertise of the operator, you can go and venture into more and more high-risk cases. LA size will be your biggest limiting factor. You need enough LA size to make your puncture and go over and then deploy your clip safely. If the distance between where you enter the LA, which is the highest point you can safely enter, and the coaxial, the plane, the mitral annular plane, if that area is less than 3.5 centimeters, it becomes very difficult to do the case. Other things like huge chunks of calcium, large gaps, all these are again further contraindications. But that being said, the pivotal deciding factor on whether you can clip the patient or no will be the TE assessment that is done by us to see if he's a viable candidate or not.
Do you consider the myxomatous nature of the valve with a very pliable, yes, whether the clip will hold on to this or not, something like following endocarditis like things?
So we do something, so yeah. So active endocarditis, we can't touch it. That is obvious. But we can't turn down myxomatous valves because a large chunk of these diseases, myxomatous valves that we get. Now, what we do in these cases is, now we have several technologies. We have the XTR technology, which is extended arms, which actually can hold more tissue safely. So you asked a very pertinent question. So what we actually do is, in India, we have only the NT. So what we actually do is we grasp the leaflet. So if you saw the first case, it was a huge myxomatous chunk of valve. You saw the leaflet jumping up, right? So what we do is we catch the valve, we check for stability, we do a tug test. Once we are fully convinced, we release it. If it's not holding properly, then we'll have to not deploy the clip.
Satish, just one more question. What is your center experience about acute MR, especially after ischemic MR or even a partial caudal rupture? We see that fairly commonly, and also sometimes in that case, whether you stent and have you done stenting at the same time and done mitral clipping? Or?
To be absolutely honest, I have not deployed the mitral clip in a single patient with acute MR. So what happened is that India till today did not have mitral clip on the shelf. So it was only special access. Now, from next month onwards, India is now on the shelf. So we have managed to get approval for India. So acute MRs don't give me the luxury to wait for the clip to come, unfortunately, right? So I have not had any experience deploying mitral clips on acute MRs. So all my cases were planned, special access. It takes 3 months for me to bring the clip in. And unfortunately, some never made it. But I've not had experience. But recently in PCT, they're publishing a registry of 93 patients in whom during acute MIs, they have results. But I've not had any personal experience.
And one limitation factor could be that LA size, right? As you mentioned, in acute MR, your LA size is quite normal, right? So is that one of the reasons that it's difficult to do?
So, one limitation could be...
No, you said that you have to have a good LA left atrial
you said
size.
about the 3.5
centimeters from the plane that you enter to the left atrium to the mitral.
Yes, especially in our population. Correct, sir.
Yeah.
That will be a big limitation. Absolutely right.
Have you had any experience on retrieval of mitral clips after the embolization? Any mitral clips deployed having had embolization, did you had an opportunity to retrieve them?
I have. No, luckily for me, I have not, because it's been extremely cautious and meticulous. You have to understand, India getting access depended on our cases. So all of them were tested, tugged, pulled, hung on until I was absolutely sure it's not moving. The clip was not released. So very quickly,
Excellent.
the first question you asked me, the name of the registry is IREMMI. This was with acute MR and shock. So this is the IREMMI registry, which was presented just a few days back. They took 93 patients in MI, some in shock, some not in shock, and studied the efficacy of Mitral Clip.
Dr. Satish, what is the durability? Do you expect any late complications related to the procedure, if any?
So I've had one complication, which was pericardial effusion. And that was because this was a very challenging case with LA was just 3 points, and she was very sick. That to a colleague's mother, a doctor's mother. So what happened is I went really high on the puncher. And I think when I did I think I went a little too high. The procedure went extremely well. She did beautifully. She even went home with trace pericardial effusion, and I was not bothered. But she came back 7 kilos heavier a week later with moderate pericardial effusion. I needed to do pericardiocentesis. I left the pigtail in there for 2 days, took everything out, and after that, she did beautifully. So that is one complication. Late complications, I don't foresee any. Most of the complications that can happen on tables. Sir.
I think we are running out of time. Thank you, Satish. Speaking all the way from Chennai, Apollo Hospitals, interventional cardiologist. Sorry, we could not introduce you at the onset. Thank you very much. Have a good day.
No problem. Thank you so much for having me with all of you. Bye.
Welcome. Bye.